Hello and welcome to my YouTube channel. Continuing our series of different surgical topics which I have been covering in my channel, today we'll be discussing one very important topic, and that is a burns management. And I would be concentrating on the initial burns management. That means from day 0 to 7, which is a very crucial period during which the patient can undergo not only hypovolemia because of fluid shift into the third space, but also patient can also undergo sepsis, which starts from 5 to 7 days. So this period is very crucial, and saving a patient and taking the patient out of the woods during this first 7 days, especially in a patient with major burns, would lead to a very satisfactory outcome and the recovery of that patient. So without wasting time, let's get started and see what are the different ways in which we can manage the burns patient, especially a patient with major burns, from day 0 to day 7. The thing which I would be covering in this topic would include initial triaging. That means at the site of the injury and in the emergency department, the triaging, followed by resuscitation, the wound care, the nutritional aspects, which is very, very important in a patient with burns being a catabolic process, and finally, control of infection, which can lead to adverse circumstances and which can also affect the recovery of the patient. So first and foremost, the step one is the triaging and the severity assessment. This is the most important part of burns management, without which we cannot proceed further. Now, for triaging, the most important thing, especially at the site of the burns, if you're called, the most important thing is that you must move the patient away from further injury. That means take the patient to a safe area, and if at all, if anything resuscitation has to be done, the patient should be immediately taken to the nearest burn center or the nearest hospital for resuscitation without wasting time. But taking the patient away from further injury is one of the most important steps. No need to wrap the patient in a thick blankets or any clothes, as it would trap the heat and would increase the total burn surface area. So the best thing is to use a cold water, a tap water, or a water which can be poured over the burns patient without wrapping. Wrapping in a thin clean sheet can be done, but only after you have taken care of the initial washing with the tap water. Now, the once the patient reaches the burns area, the total burn surface estimation is one of the most important things which would guide us in further managing the patient in the form of IV fluids and the nutritional requirements. So I think all of you are aware that the most common way of calculating the total burn surface area is the rule of 9, which goes by the name of Wallace's rule of 9. Now here, and this we are taking for adults. Mind you, this we are taking for adults. Here, what we do is that the head and neck would constitute 9%, the interior trunk, that means the interior chest wall and the interior abdominal wall, would together constitute 18%. Each leg would constitute 18%. Each arm would constitute 9%, as shown in this diagram. The posterior trunk, that means the posterior part, upper back and the lower back, would constitute 18%, and the perineum would include 1%. There are different ways of calculating. We have a Lone Browder chart also, and roughly you take the patient's palm as corresponding to 1% of surface area or total burn surface area. That is a roughly you can estimate by taking the calculation as 1% for the patient's arm. Now, of course, in children or in pediatric age group, this rule of 9 is slightly different, because in pediatric age group, the head and neck would constitute a significant proportion of the total burn surface area. The burn depth calculation or classification is also very important for guiding the management. Traditionally, the burns have been divided into superficial burns and deep partial burns and full thickness burns. So, superficial burns, what we call the first degree, which consists of only erythema. There are no blisters, and this is a very painful burn. So, it's just a superficial erythema without any blisters, and it is painful. Then we have superficial partial and deep partial, which are categorized as second degree. Now, in second degree burns, we have blisters, which are moist and they are very painful. Whereas full thickness burns, which is third degree, the tissue becomes leathery, it is devoid of any sensation, it becomes insensate, and the external appearance appears like a waxy, charred tissue. And the fourth degree traditionally would involve not only the deeper tissues but also the muscle, the bone, and even tendon involvement. So superficial would be only erythema, which is first degree. Second degree would consist of blisters, which are painful, and then we have full thickness, third and fourth degree, where the tissues are leathery, and in the fourth degree, even the tendon, bones, and muscles are involved. Now, what is the criteria for a patient to be referred to the nearest burns unit and admission in a burn center? Now, there are set criteria. The first criteria is any burns of more than 10% of total burn surface area in an adult or more than 5% of total burn surface area in a child should be referred to the nearest burn center and for admission and further management. Any full thickness burns more than 5% of total burnt surface area, that would be the second criteria. Any burns involving face, hands, feet, external genitalia, and major joints would require admission and further management in a specialized burn center. Any circumferential burns because of risk of compartment syndrome would warrant admission. Any inhalation injury or an airway injury is again an important parameter for admission of a patient. Electrical burns or chemical burns, burns with other major trauma or other comorbid conditions. They may be associated fractures or head injuries, abdominal injury, or there may be other comorbid conditions a patient may be having, like uncontrolled diabetes or immunosuppression. These patients would also require admission. Extremes of age, any patient who is less than 5 years or more than 60 years would would be admitted to the nearest burn center. Now, this is the major criterias for the patient to be referred to the burn center and for the admission and further management. Now, day zero, the first thing which we will do when the patient is being seen in the emergency room is to take care of ABC, that is airway, breathing, and resuscitation. Always assume that patient has inhalation injury and treat accordingly. So, airway management is the highest priority on initial assessment of the patient. And what are the signs, typical signs of inhalation injury? When you see a patient who has got a singed nasal hairs or eyebrows, then always assume that there may be an inhalation injury. Any patient who is not able to speak, there is a hoarseness of voice, patient has got obvious stridor, or there is a change in the quality of the voice, always assume that there is an inhalation injury. Sooty sputum or carbonaceous sputum is another indication. Any facial burns or oropharyngeal burns would imply that possibly this patient has got inhalational injury. Similarly, any patient having dyspnea, cyanosis, or, or SpO2 less than 95% would be assessed as a case of inhalational injury. And what is the management for such a case where you suspect inhalational injury? Immediate early intubation if any airway compromise is suspected. Do not delay. That is the most important step. Give 100% oxygen via non-rebreather mask. Carbon monoxide poisoning should be excluded. And if inhalation is confirmed, immediately once the patient is stabilized, try to do a fiber optic bronchoscopy and visualize. But oxygen and early intubation would be one of the life-saving measures after of on taking care of airway. Then comes the IV fluid resuscitation, which is the very important step in the management of a patient. Now, why this is important? Because in the first 24 hours, the capillary permeability increases. So all the fluid from the intravascular space would extravasate into the extravascular space and into the third space because of increased capillary permeability. And this would lead to a patient having hypovolemia and going into hypovolemic shock and its further complications. That's why IV resuscitation plays a very important role in the initial management of the patient and its final outcome. Immediate to large bore IV cannula should be accessed as early as possible. If there is no healthy skin through which we can go, you may have to go through the burn tissue also. Immediately catheterize the patient because strict hourly urine output is mandatory. Intake output chart is mandatory in such a patient. Put a nasogastric tube or a Riles tube if there is a 20% or more total burn surface area, because of the risk of paralytic ileus which may occur, leading further complications. Patient should be monitored on a continuous ECG and NIBP monitoring, especially in electrical burns also, and pulse oximetry and arterial blood gas analysis and carbon monoxide hemoglobin assessment should be done as early as possible. As you're getting the resuscitation of the patient simultaneously, certain blood samples may be collected for investigations, which include a full blood count, renal function test in the form of blood urea and serum creatinine, liver function test, coagulation profile, that means prothrombin time, INR and activated prothrombin time. Arterial blood gas analysis is very, very important. Serum electrolytes, blood glucose monitoring, blood grouping and cross matching, chest x ray, ECG monitoring, and urine analysis, especially to rule out myoglobinuria if you're suspecting electrical burns. So, these investigations, the sample should be sent simultaneously as the resuscitation is going on. So, by the time you go into the actual management of the patient, the reports are ready in your hands and you can modify your treatment accordingly. Now, for IV fluid resuscitation, the classical formula which is used is Parkland formula. And the Parkland formula is a very simple formula to calculate the fluid requirement in the first 24 hours after burns. The formula is 4 milliliters per kg body weight per total burned surface area. So half of the calculated fluid would be given in the first 8 hours. And this 8 hours would start from time of burns and not on time of arrival to the hospital. This is very important. So if a patient is burnt at 10 o'clock and if he reaches the hospital at 11 o'clock, that means you would calculate the fluid requirement that first 8 hours from 10 o'clock and not 11 o'clock. That is at the time of the burns and not at the time of the arrival. The next half of the fluid would be given over next 16 hours. And the fluid of choice is a Ringer's lactate or Hartmann's solution. And the target urine output which you would like to keep is 0.5 ml per kg per hour is the minimum. Ideal in an adult would be 1 ml per kg per hour, but the minimum would be 0.5 ml per kg per hour. So a 70 kg normal adult should produce at least 70 ml of urine in 1 hour if your IV fluid resuscitation is adequate. In children, target for a urine output of 1 ml per kg per hour. Add colloids, albumin 5%, which is a classical colloid which is used. Of course, you can also use dextran solutions like dextran 40 and 70 or Heta starch or certain blood products like fresh frozen plasma. But 5% albumin colloid is one of the most commonly used colloids, but it has to be added only after 24 hours. The rationale behind this is that in the first 24 hours, as such, there is increased capillary permeability. So if you give colloids or albumin in the first 24 hours, they would not stay within the intravascular space and they would go and extravasate out into the interstitial space and into the third space, resulting in their neutrality. So the colloids should only be added after first 24 hours. After first 24 hours. The first 24 hours is only reserved for crystalloids. And colloids are to be added only if the total burnt surface area is more than 20%. Anything less than that, depending on the patient's to patient's clinical scenario, you may also give a miss to the colloids if the TBSA is less than 20%. Titrate your fluid requirements strictly according to the urine output to maintain that minimum urine output. The wound care, initial first aid is very, very important for a final outcome and recovery of the patient. Ideally, the wound should be washed with a cool running water for at least 20 minutes if the patient is seen within 3 hours of burns. Remove all the clothing and jewelry. Do not apply any ice, butter, or any other home remedies. Cover the patient with a clean film or a cling film. Lay longitudinal, not circumferential, and keep the patient warm, because these patients can quickly go into hypothermia, which can worsen the outcome, which can worsen the metabolic acidosis, and which can also lead to increased predisposition to sepsis. Tetanus prophylaxis, tetanus toxoid should be given in a patient after assessing the immunization status accordingly. Continuing your fluid continuation, wound assessment, and the initial first dressings on day 1 to 2 of burns. So, day 1, the fluid management, that is from 24 to 48 hours. Continue Parkland, the second half over 16 hours, which we have already discussed. Titrate your fluid requirement rate according to the urine output to maintain the target urine output of at least 0.5 ml per kg per hour in adult. Ideally, should be 1 ml per kg per hour, and in children 1 ml per kg per hour. Decrease the IV fluid rate if the urine output is more than 1.5 ml per kg per hour consistently. Monitor serum electrolytes, hemoglobin, and lactate, which is a marker for sepsis, every 8 hours. Use urine dipstick for assessing any myoglobinuria, especially in electrical burns. For wound assessment in day 1, first formal dressing change should be done on day 1. Again, reassess the burn depth, because the edema may disguise the depth of the burn. So as the edema subsides, the final depth of the burns and the total burn surface area can be reassessed again, and if required, IV fluids and other things can be tailored accordingly depending on the latest TBSA. What to do with the blisters? Leave the blisters intact if they are less than 2 centimeters and have intact roof. Don't try to puncture them and increase the chance of any infection. Any devitalized tissue, any burnt tissue should be debrided under analgesia. Under no circumstances a dead tissue or a devitalized tissue should be kept, as it can lead to increased chances of infection. Photograph the wounds initially as a baseline documentation, and consider wound swab only if the infection is suspected. Otherwise, the initial first 48 to 72 hours, wound swab would have no role to play. What are the dressing selection guides? For a superficial wounds, just use any non-adherent dressings. And for deep wounds, you can use any Aquacel or silver sulfadiazine 1%. For full thickness burns, patient would require at least a grafting, which we will discuss later on. Fluid transition and colloid phase on day 2, that is 48 to 72 hours. Transition to 5% dextrose plus 0.45% of saline with potassium chloride as a maintenance fluid. So from 48 to 72 hours, Ringer's lactate can be transitioned into 5% dextrose with half strength, that is 0.45% of normal saline, and depending on the potassium requirement, you can add potassium chloride also to this solution, and keep it as a maintenance therapy and titrate it according to the urine output. Add colloid, we have already discussed, on after 24 hours. Albumin 5% if it is more than 20% of total burnt surface area, or if the patient has hypoproteinemia, irrespective of the TBSA burns. Monitor weight gain. Target hemoglobin to more than 8 grams per deciliter. If the patient's hemoglobin is less than 8 grams per deciliter, ask for blood transfusion to keep the target at 8 grams. Encourage patients to take oral fluids if the patient is able to tolerate oral fluids and GCS is intact, because early nutrition, enteral nutrition, would prevent the gut integrity to be compromised, leading to the translocation of bacteria. So the early enteral nutrition should be encouraged in such patients. Review nasogastric tube whether it is actually required or not. If the ileus is not there, then you can take out the nasogastric tube and continue oral fluids if the patient is able to tolerate. Wound assessment and nutritional initiation on day 2. Second dressing change would be done after 48 to 72 hours. Again, reassess the formal depth and TBSA. Superficial, partial, non-adherent moisture retaining dressing should be done. Now for deep wounds, we have to plan for an early tangential excision and grafting, which we will discuss later on. But for any deep wounds, especially deep partial wounds, tangential excision and grafting should be considered from 48 to 72 hours following burns. Assess scar. Scar is the dead tissue which appears like a blackish necrotic area, especially in deep burns, and they can cause a lot of complications, especially if it is circumferential. So assess scar for any rigidity or soft or pliable. Early enteral nutrition we have already done should be started within 6 hours of admission, especially in more than 20% of TBSA. Because the burns is a high stress event, it's a catabolic process, the patient requires more than normal requirement of proteins and calories. So aim for a protein intake of 1.5 to 2 grams per kg per day, as opposed to a normal requirement of about 1 gram per kg per day. Calorie requirement should be 25 to 30 kilocalories per kg per day. Vitamin C should be given in the dose of 1 gram per day to promote wound healing, and zinc sulfite and vitamin A supplements should be added from 48 to 72 hours. Day 3 is a diuretic phase where we concentrate on fluid and hemodynamic management. Again, wound and physical rehabilitation, and here the chances of infection and sepsis would start to creep up now. So first, from day 3, fluid and hemodynamic management. The diuretic phase begins somewhere around 3 days, that is 72 hours post burns, when the mobilization of interstitial edema fluid would occur, and a brisk diuresis is expected, and you may see the patient having an increased urinary output. In such a case, wean IV fluids cautiously as oral intake resumes from day 3. Monitor for pulmonary edema, because there is always a chance, especially in elderly patients, of over resuscitation with IV fluids leading to pulmonary edema. Monitor electrolytes because of increased diuresis. Daily do serum electrolytes in the form of close watch on potassium, sodium, magnesium, and phosphate. Hypophosphatemia is always common in this phase. Replace it with IV or orally. And DVT prophylaxis should always be looked for. Continue patient may be kept some physiotherapy of the lower limbs. Similarly, if required, you can start low molecular weight heparin or unfractionated heparin, especially in high risk cases. For wound and physical rehabilitation on day 3, formal wound assessment. Formal wound assessment and formal depth evaluation should be done. Superficial partial healing, reassess on day 7 to 10. Tangential excision, we had already discussed. Ideally, tangential excision should be done on day 3 to 5. That is the ideal window of doing a tangential excision and skin grafting, split skin grafting. And watch for any early wound infection signs in the form of any discharge or purulent discharge. Physical and occupational therapy should be started here. Active mobilization begins on day 2 to 3, including all joints. Splinting and anti-contracture positions should be given. Pressure garments should be done as a discussion and early planning. Passive movements of the burn joint should be done by physiotherapist, and elevation of burned limbs to reduce edema should be done. So physical and occupational therapy play a very important role in final outcome and prevention of bone contractures. Infection and sepsis surveillance is very, very important. The clinical signs to monitor are any patient having fever more than 38.5 degrees centigrade or hypothermia less than 36.5 degrees centigrade, patient having tachycardia, hypotension or tachypnea, any wound showing greenish or brownish exudate or foul odor, edema or erythema of the wound extending beyond the burnt surface area, and the most important is altered consciousness or confusion in a burn patient is the earliest sign of sepsis. Look out for that. Lab markers which would suggest infection creeping in is any leukocyte count more than 12,000 per cubic millimeter or less than 4,000 per cubic millimeter, C-reactive protein more than 150 milligram per liter, wound surface culture if you take and it shows more than 10 raised to power 5 organisms per gram of culture, and take 2 sets of blood cultures before starting the antibiotics if sepsis is suspected. Treatment principles are: don't give any prophylactic antibiotics unless the infection is confirmed. Treat only confirmed infection. And the ideal antibiotics are for gram-negative piperacillin and tazobactam. For gram-positive, a vancomycin would be flucloxacillin would be an ideal choice. Topically, silver sulfadiazine or mefenadine acetate is one of the most important topical agents to apply. Source control, that is early excision of devitalized or burnt tissue, is very important to prevent sepsis. Now, day 4 to 5 is the day when we cater for nutrition, ongoing wound care, and psychosocial support. The nutritional support, we have already discussed, patient would require at least 1.5 to 2 grams of per kg per day of proteins, 25 to 30 kilocalories per kg per day of calories, 1 gram per day of vitamin C, and at least 220 milligrams per day of zinc. Oral route is always preferred. Encourage a high protein, high calorie diet. Nasogastric feed can be given if oral feed is less than 60% of the target by day 2. Parenteral nutrition indicated only when the patient cannot take enteral nutrition. Patient should be reviewed by dietitian daily to monitor the nitrogen balance and monitor the dietary requirements. Avoid overfeeding, which can worsen hypermetabolic response. There are certain supplements and micronutrients which the patient would require in major burns. Multivitamin supplementation daily. Vitamin A, 10,000 international units per day for immune modulation. Selenium, which is a very important mineral and micronutrient which can be used as an antioxidant in the dose of 300 micrograms per day. Vitamin B1 or thiamine, especially in alcohol related injuries. Monitor serum magnesium, calcium, and phosphate daily in such a patient. Continuing our wound care on day 4 to 5, dressing changes every 48 to 72 hours. Dressing should be done under sterile aseptic conditions, taking proper precautions and using the burn center dressing rooms. Honey-based dressings can be used as an alternative. Always debride slough and necrotic tissue with each dressing change to prevent any superadded infection. Take wound swab if you feel that there are signs of infection, which we have already discussed. And always measure the wound size to track the healing process. Ideally, as the wound heals, the wound size should gradually reduce. Psychosocial and multidisciplinary care is one of the integral parts of successful outcome of a burns patient. Patient should have an assessment by a psychologist to overcome the stressful situation the patient had undergone. Pain anxiety cycle should be addressed proactively. PTSD, post traumatic stress disorder screening, especially in children and facial burns, should be done. Family should be supported and counseled. Social worker input for housing, finance, and other things should be looked for. And occupational therapy in the form of goal planning and the further occupational rehabilitation should always be encouraged at this stage. Bowel care is very important because these patients may also have constipation, paralytic alias. Opioid induced constipation can also cause chronic constipation in such cases. So, give high fiber diet, give regular lactulose and senna to prevent any constipation. Day 6 to 7 is the surgical part, that is the excision and skin grafting. So, what is the pre-operative preparation in such a patient? Optimize electrolytes. That is one of the most important thing. Optimize electrolytes. That means sodium potassium should be optimized. Keep 2 to 4 units of packed RBCs ready before you go in for any surgical procedure, be it a tangential excision and skin grafting. Target a hemoglobin preoperative of more than 10 grams per deciliter. Avoid dehydration, so fluid requirements should be ideally tailored and titrated. Stop if the patient is on low molecular weight heparin to prevent deep vein thrombosis. Stop low molecular weight heparin at least 12 hours preoperatively and unfractionated heparin at least 4 to 6 hours preoperatively. Take consent from the patient, including risk, donor site, graft failure. Theatre should be adequately warmed to prevent any intraoperative hypothermia. And anesthesia, tumescent infiltration reduces bleeding. Now, what is the main surgical procedure you can do on this day 6 and 7? Is early excision, which is a tangential excision as shown in this diagram. The ideal timing is day 3 to 5 in a stable patient. What is done is that a tangential excision of all the necrotic tissue, including ischar, is done in the patient with major burns. The excision is carried out layer by layer till the healthy tissue is reached, which indicates there is active bleeding and viable tissue is seen. Limit 20% of total burn surface area only of tangential excision per session, because this procedure can lead to severe blood loss. Hemostasis should be addressed to by adrenaline soaked swabs. You can give a temporary cover of a biobrain or an allograft if the actual graft is unavailable. What is the benefit of early tangential excision? It promotes early healing of the wound, prevents further infection of the wound, and also reduces the hypertrophic scar formation. Once the tangential excision is done, then we can use a covering of the tissue with a split skin graft. Thickness ideally of split skin graft should be 0.2 to 0.3 millimeters, harvested with a Humbee's knife or a Zimmer dermatome. Donor size, generally it is taken from thigh or buttocks, and always used a mesh graft, especially for trunk and limbs. Fix it with sutures or staples or even tissue glue, and post graft immobilization at least for 5 days to prevent any graft movement and rejection of the graft. The post operative graft care and graft monitoring. Non adherent layer directly on the graft. Absorptive outer dressing. First check should be done on day 4 to 5 post grafting. And what are the signs of the graft take? That the graft would be adherent, it would be pink and appears viable. That is the most important thing. Don't try to see the dressing before 4 to 5 days post graft. What are the graft failure signs? If there's any hematoma or a serosoma which may have been accumulated under the graft, any movement or shearing forces may move the graft and reduce the chances of graft taking. Any infection which may also preclude a successful graft take. If the graft color is not pink and it appears to be pale or dark or mottled, then possibly the graft has failed. Continue physiotherapy, continue pressure garmenting and compression garments, and continue nutritional support on days 6 to 7. And keep a close watch on fluid requirements and urinary output, as well as signs of infection and sepsis. Analgesia plays a very important role in initial management of burns. For that, we use generally a multimodal analgesia ladder, which is proposed by WHO, also known as WHO pain ladder. The step one of the WHO pain ladder for initial management is any NSAIDs like paracetamol you can give, or 4 times a day, plus NSAIDs you can add if there is no contraindication for its use. If the pain is not controlled with NSAIDs and paracetamol, then we can add oral or IV opioids, morphine in the form of 0.1 milligram per kg IV titrated. 0.1 milligram per kg IV titrated. Step 3, if the patient still is having pain, then we can go into IV or intramuscular ketamine, zero point 0.5 to 1 milligram per kg, which is a dissociative analgesia. And we can also use anxiolytics like IV midazolam 0.02 to 0.05 milligram per kg pre-procedure. Special mention about iscarotomy. As we have seen, iscar is a dead tissue which may be circumferential and can lead to compartment syndrome, because this circumferential tissue acts like a constricting agent and may prevent and may cause distal ischemia and increased venous pressure, leading to compartment syndrome. So these are commonly seen in circumferential full thickness limb burns, ISCAR. So iscarotomy especially is done if you see a circumferential full thickness limb burns, because if there is any evidence of compartment syndrome in the form of distal ischemia, the pulses may be weak or there may be some skin changes distally. In that case also you would do iscarotomy to prevent compartment syndrome. Circumferential chest burns is another indication for iscarotomy, because this can cause ventilatory or respiratory failure. And rising compartment pressure in limb to more than 30 millimeter of mercury is also one of the important indications for sclerotomy. And what are the sites and incisions? The sites are generally in the limb. We give a medial and a lateral longitudinal incision. That means along the entire length of the limb, give a longitudinal medial and a longitudinal lateral incision. This would release the pressure and prevent complications of a compartment syndrome. In the chest, we give bilateral anterior axillary or subcostal plus subcostal incision. So anterior axillary fold bilaterally, you give an incision and plus a subcostal incision to release pressure, especially in circumferential chest burn. In the digits, we give mid-lateral incisions and always extend through the scar, right, go up to the subcutaneous fat. Post procedure, you always expect bleeding. Hemostasis should be adequate. Cover with the silver containing dressings. Reassess early to prevent and assess compartment syndrome. Fasciotomy, if sclerotomy is unsuccessful. Fasciotomy can be done. That means the fascia can be incised if sclerotomy is not successful. A word about electrical burns. Always assess an entry and exit wounds. Cardiac monitoring is very important in electrical burns, at least for 24 to 48 hours to prevent arrhythmia. IV fluids, target urine output of 1 ml per kg per hour. There is always a real danger of myoglobinuria. So alkalized urine with sodium bicarbonate. Mannitol is to be given if myoglobinuria persists. Here, fasciotomy or sclerotomy, if compartment syndrome occurs, is very important, and neurological and ophthalmological review should be done regularly in such a case. In chemical burns, copious water irrigation in the initial phase, at least for 45 to 60 minutes, is one of the most important steps. Copious water irrigation. Do not neutralize, especially ocular burns, always irrigate with 1 liter saline. Remove any contaminated clothes which which may cause more damage, and toxicology specialist input should always be taken for managing such burns. So, coming to the end of this topic, key takeaways from burns management from day 0 to 7 is: day 0, resuscitation clock starts at the time of burns, not hospital arrival. Parkland formula is 4 ml per kg per percentage TBSA. Step number 2, titrate IV fluids to urine output. Target ideally 1 ml per kg, minimum 0.5 ml per kg per hour in adults. Decrease the IV fluid rate if urine output exceeds the target by 1.5 ml per kg per weight. Daily weight monitoring is to be done. Step number 3, especially cool the burns, not the patient. 20 minutes of cool running water within 3 hours of burns is life-saving. No ice. Keep the patient warm. Hypothermia worsens coagulopathy. Early airway. If inhalation injury is suspected, intubate early before edema makes it impossible, because there is always a chance of laryngeal edema. 100% oxygen by non-breather mask. Early enteral nutrition to be started within first 6 hours of burns, especially if the TBSA is more than 20%. High protein diet with a requirement of more than 1.5 to 2 gram per kg per day, and calories of more than 25 to 30 kilocalories per kg per day should be given. Nasogastric tube feeding only if oral intake is inadequate or patient cannot take orally. Don't give prophylactic routine antibiotics as it increases resistance. Treat only microbiologically confirmed infection. Wound swab would guide your antibiotic therapy. Early tangential excision is life-saving. Excision plus grafting, day 3 to 7 window, improves the outcome of the patient, reduces the infection, reduces the hospital stay, and hypertrophic scar formation. Burns management is a multidisciplinary team effort. So not only the surgeon, but also a good nursing care, a good nutritional support from dietitian, physiotherapy, OT and associated staff, psychiatric and psychological counseling, social work plays a very important role in final outcome and satisfactory outcome of the patient. And scar management begins at day 1 planning only. So this is in nutshell the initial management of a major burns patient. I hope you have liked this video. If you have liked it, kindly subscribe to our channel and like it and share it with your colleagues and your batchmates. And I would keep coming with such topics regularly with your encouragement and support. Thank you for your time and thank you for watching.